We are so happy to have all of you here with us today. We are featuring this opportunity today to be one of the webinars that we are providing for the grantees of our ACL-funded Bridging Aging and Disability Network grant opportunity. But we've also opened this to others from DD Council. So we're glad to see many of you here. And I'm sure some others are still popping in, but I am going to go ahead and get us started today by introducing our guest speaker today, Matt Janicki. Matt Janicki, PhD, is the co-chair of the U.S. National Task Group on Intellectual Disabilities and Dementia Practices, as well as a research associate professor in the Department of Disability and Human Development at the University of Illinois at Chicago. He is also a member of the U.S. Federal NAPA and APA Advisory Council on Alzheimer's Research, Care, and Services. Previously, he served as Director for Technical Assistance for the former Rehabilitation Research and Training Center on Developmental Disabilities and Health at the university. Was Director for Aging and Special Populations for the New York State Office for People with DD, and spent a year as a Joseph P. Kennedy Jr. Foundation's Public Policy Leadership Fellow at the U.S. National Institute on Aging and the U.S. Senate. And Matt, that is something that I did not know about you. And we should talk about sometime because I'm always supporting the Kennedy Fellows.
Thank you. Yeah.
So
it was a wonderful year.
Wonderful. Yeah, that's great. So listen, I could go on and say a whole lot about Matt and his past experience, but I think the most important thing to share is that Matt is definitely either one of, if not the expert on IDD and dementia. And Matt has so much to share with us today that I think is going to be helpful for all of you as you work on your grant projects and you think about the work that you are doing. I know Matt is going to be working in depth with the project in Hawaii coming up over time, or at least folks from your NTG. They are on with us today as well. But I think what you're going to be doing today, Matt, is really setting that foundation with some basic background and information that is going to be helpful to all of us. So, Matt, thank you for being with us today and bringing your decades worth of commitment to this issue and this topic to all of us to share. So I turn the floor over to you.
Okay, great. Now, I need to take over the screen. If do you do that? You share the screen with me, or do I do it from my end?
Robin, does he have the permission to?
Yes, you should be good now.
All right, so I just need to get into my PowerPoints, right?
Yes.
Okay, can you see them now?
No, not yet.
Okay. I don't have that little block in there that shows me that you can see me. Let's see. Do I have to? I wonder if I have to do something more at my end.
No, you should be able to. Everything is set where you should be able to share what you're looking at.
Do I have to hit share screen?
Yes.
Oh, okay. I guess that's the first thing to do. All right. There, that's good. Oh, I can see you and you can see me, right?
Yep, we've got it now.
Okay. As I was saying earlier, before when you came on, I'm in a room that's going to be facing the sun in a few minutes. It's going to wash me out. So I'm probably going to get off camera when that happens. So if you don't see me, I'm still here, but I don't want to look like I'm bathed in the sun. I'm up in Maine, so we're starting digging out of our northeaster that we got a few days ago. I hope your weather is better than ours. Thank you very much for that kind introduction, Donna. I'm going to cover a number of areas that kind of give you maybe a large picture, then kind of narrow it a little bit down to activities that you can do related to, as on the screen it says, risk reduction, brain health, and intellectual and developmental disabilities. One of the other things that I'm involved in, and this is the things you mentioned, is also part of the CDC grant on the Healthy Brain Initiative at the University of Illinois Chicago with Beth Marks and Yasmina Cicerek And we have an association through the NTG with those fellows. So I'm going to be talking about some of the CDC's things as well. I also wanted to mention that in my previous history, when I was still employed by the state of New York, I did represent the state DD agency on the DD council when the commissioner didn't attend. So that was one of my roles. So I'm kind of familiar with the role of councils and what you do, and praise you for what you do, because there was a lot of investment in aging in New York at that time. And I also noticed some familiar names that from the folks that did sign in. Okay, so let me start with the big picture, which is basically dealing with the National Alzheimer's Project Act. This is the legislation that was passed in 2010 and signed by President Obama that basically drives a national Alzheimer's plan. And it's requires the federal government through DHHS, Department of Health and Human Services, to create a national Alzheimer's plan. They initially did one in 2012, and then subsequent updates. I happen to have the honor to be able to serve on the council at this point, on the federal council that advises the Congress and the department and the president on issues related to Alzheimer's. So I think I'm the only person that represents intellectual development disabilities. So I sort of have an interesting perspective on things there. The council is basically made up of both presidential appointees, which are the non-governmental people, and federal agency staff, which is one of the few federal councils that's made up of both federal employees and non-federal employees. And that offers us an opportunity to have very direct contact and discussions going on among ourselves, particularly what the federal agencies do. And there's a lot of impact from that plan on the federal initiatives that have come up each year and how they budget for things. You can see on the screen some of the things that the national plan calls for. There's incidence and practice guidelines and assessment tools for detection and cognitive diagnosis of cognitive impairments. A lot of emphasis on supporting caregivers, a lot of emphasis on research. And there is an emphasis also on special populations, including people with Down syndrome and intellectual and developmental disabilities, which is the praise in terms of that. So that's the NAPA Council. There's a tie-in for provider agencies across the country and for councils as well, one of which is the tie-in to state Alzheimer's plans, the objectives they produce, and perhaps even the state DD plans in terms of correspondence if there is an Alzheimer's plan in your state. And they may even be a representative from that organization. It might be a health agency that's on the council. And then there's also tie-ins with what they call the GWEPs now, used to be the GECs, which are the geriatric workforce enhancement programs. And these are the folks that have got a lot of money coming out of HRSA, which is one of the federal agencies that funds training, to do training in the area of geriatrics and gerontology. And now that program is focusing more on the workforce, the people that support older people who may have dementia. So there's a nice tie-in there for education and training programs in your state. There's also some potential implications from CMS's setting rule in terms of providing dementia housing in the community and community-based services under the HCBS aspects. And then also a tie-in to CDC's Healthy Brain Initiative, which I'll talk about in a few minutes. And then the other thing that it might be something of value to you and interest is the Alzheimer's Disease Program Initiative, which comes out of HCL, the Administration on Community Living. And they 2 or 3 times a year, they issue a grant notice for 3-year grants to do demonstrations, innovative programming and issues of dementia, and including one of the focal areas is intellectual disabilities. So some of you may be familiar with those grants and even be collaborating with an agency that got one of them. They're very worthwhile. They do a lot of productive things. Just segueing a little bit over to the CDC structure, the bold infrastructure for Alzheimer's Act is basically what underwrites and kind of governs what CDC does in this area. And this is where the focus on Alzheimer's comes out of CDC. And it was really kind of an amendment to the Public Health Services Act. And it looked at creating some national policy coordinates by CDC under what they call the bold initiatives, basically directed at early detection and diagnosis, early risk reduction, preventing of avoidable hospitalizations. And this is related to people who may be affected by dementia and supporting dementia caregiving. So it's quite a large initiative, and it's been growing considerably since 2018 with additional appropriations every year for more programs. And these programs part of the programs that were originally implemented by CDC is the Dementia Roadmap, which is now being updated, which should be coming out sometime later this year, and some other aspects. There is basically a definition that talks about brain health, which is what this all geared up to be. But the theory here is that you don't want to work at the tail end of the disease. You want to begin at the beginning of potential beginning of a disease like Alzheimer's. And so you can affect change in the brain by doing certain things in lifestyle change and nutrition, exercise, a lot of other things that we'll discuss in a few minutes that affect brain development and brain health, and consequently minimize the opportunity for brain diseases to begin to take over an individual. So that's what this is all about. And this kind of stems from a World Health Organization initiative on brain health. The other aspect of this CDC effort is, hang on, I gotta just take one of these little things off here, is the Bold Public Health Centers of Excellence program. And there's a number of centers that have been funded now under this issue. They wanted in the Alzheimer's Association has a wonderful center on dementia risk reduction. They're actually having a great meeting and coming up at CDC headquarters in Atlanta in mid-May. It's like a conference on risk reduction and brain health. And then the NYU School of Medicine has one on early detection of dementia, and their focus is trying to anticipate how to find the signals of dementia before they occur and are presented so that they can anticipate things. And the University of Minnesota has one on dementia caregiving. And then there's grants to various states and localities on public health programs. And then there's the Healthy Brain Initiative, which is where the UIC is part of. And there's a little graphic here that shows you there's a National Healthy Brain Initiative collaborative that involves those other centers I mentioned, involves the various public health programs around the country that have these grants from CDC, and also the Healthy Brain Initiative grantees. And there are 3 Healthy Brain Initiative grantees. One is the UIC one, which focuses on intellectual disabilities. There's one at Us Against Alzheimer's, which focuses on populations of color, particularly African-American and also the Spanish-speaking individuals. And then the last one is the Indigenous Association, International Association for Indigenous Aging, which has a target as people who are from Native American population. And these kind of the combined effort of the collaborative, and we're all trying to do our best in terms of representing different sectors of the group to make sure things happen well and are focusing on healthy brain things. So that's sort of the area there. I guess I jumped the gun. Here are the 3 different programs that are focusing on healthy brain. We call it Component B. And this is all sort of coordinated by what we call a Component A program, which is the Alzheimer's Association out of Chicago. And each of these have websites that are designed to give you information about what's happening in their areas. One of the things here is just to kind of give you a little bit of a history of the Healthy Brain Initiative. It kind of started with support back in 2005 through congressional appropriations and language, and then moved into a national public health roadmap for maintaining cognitive health, and then moved into a healthy brain thing. And then the National Alzheimer's Project Act, which was signed in 2010, a national plan came out in 2012. And then the public health roadmap for state and national partnerships that followed, which is now being updated. And then there's another roadmap came out after that. And then the Healthy Brain Roadmap for Indian Country, which is another one that's available. So that's sort of the trajectory of this whole thing in terms of a trail. And the notion about brain health is there are 6 pillars that you're going to focus in on. Physical exercise, food and nutrition, health checks, sleep and relaxation, mental fitness, and social interaction. And those are the targets of a lot of the programs that are being funded by CDC in terms of initiatives, education, and other aspects in terms of making a healthier population, in terms of long-range effects when the people become older. One of the underlying principles of and efforts that is being undertaken now is strongly being shifted over from public health and physical health is social determinants of health. The principle here is that there are a lot of things that go on in the environment that affect health. There's some wonderful presentations that are being offered now showing the effects of institutional racism in terms of how it affects population development and population brain health in terms of stress factors, lack of nutrition or access to good nutrition, exercise, and other factors that create problems in terms of healthy brain development. all those things are being factored into the efforts that CDC is doing. So there's a big focus now. This is where some of the things that you might be doing at the council level kind of can focus as well as in terms of encouraging organizations under your aegis and funded, and even affecting what the state agencies do in your state to kind of focus more on social determinants of health in terms of preventing conditions that may affect disability, but also affect healthy brain issues. So you can see from this, it's kind of involved, but it does give you some flavor of what's going on in that area. The WHO recommendations look at some of these areas that interventions can occur, and they look at what the evidence is in terms of backing it. The physical activity interventions, usually there's a very strong bit of evidence that physical activities do help reduce risk of cognitive decline. And you see that in a lot of the recommendations for keeping older people engaged in physical activities, and active social life and things like that. Nutritional interventions are another factor. The evidence is strong there again, that a healthy, balanced diet can reduce risk of cognitive decline. It's sort of the opposite of having a McDonald's diet, but moving over to like a Mediterranean-like diet, which is recommended, where you have fruits, vegetables, and protein and things like that, and low-fat items. And then the cognitive interventions, evidence is somewhat low on cognitive exercises that they work in terms of reducing risk, but any cognitive stimulation helps train brain function. So that's always a factor. And then the social activities, social participation and social support is strongly connected to good health and well-being, and thus can mitigate mental health issues. And this kind of maybe relates to some of the things that you may be doing in terms of promoting inclusion at the local level and making sure that people are involved in social activities and are not isolated and segregated, and also involved in anything that encourages them to interact on a cognitive level, as well as improving their diets to reduce obesity levels and overweight levels. Also, sort of behind the scenes is the succession of excessive alcohol and tobacco use, which is a factor in most general population, maybe less so in the intellectual disability population. So that's kind of a quick summary of where CDC is doing with brain health, and that might affect some of the things you do. And they have some wonderful materials on their websites that you can access and pull into whatever structures you're developing at whatever, in whatever area you're going. Let me give you a little quick tour of the National Task Group. We've been around since 2011. We're now a non-for-profit corporation. And our mission basically is to advocate, educate, and provide technical assistance and program protocols and guide public policy in areas of intellectual disability and dementia. And we have affiliations with various other national groups like the National Down Syndrome Society, Lumine Foundation, Lead Coalition, a number of university programs and community organizations. We do a lot of interagency networking. And back in 2012 or so, we produced what we called my Thinkers Not Working document, which was kind of a plan in terms of what the country needs to do to really address dementia as an issue and related to the intellectual disability population. And where my Not Working came from is that I visited a group home in Nebraska a number of years ago, and we were talking to a fellow that was starting to show some mild cognitive impairment. And one of his comments was, my thinker's not working. We kind of picked that up and thought it was a good way to characterize the notion of how people perceive it from when they're in. On the right-hand side of the slide, you see some of the things that we do. And so we're involved in a lot of different activities. We're a voluntary group, basically. We just added a staff person now to help direct our operations, which is a step in the right direction. So here's some of the functions. Basically, we're involved in advocacy, education, training, family assistance, supports, policy, information dissemination. We're heavily into diagnostics and assessment and national and international connections. And on the right-hand side of the graphic, you can see some of the things that we've produced. There's a lot of materials on our website, which is shown in the lower left-hand corner of the slide. You can access all these for free. There's no charge for them. We kind of put them in the public domain. We also were the first organization in the country to produce a screening instrument so that agencies and organizations and family members could fill out and note who may be showing some signs of early cognitive decline and present that to an examining physician and say, have a discussion around what they see and get some sense back whether it's related to something like Alzheimer's disease or some other factor that may be affecting brain health, or maybe some other condition that could be treatable and turned around. So I welcome you to kind of tackle our website and call through it. You'll see a lot of interesting things that might be useful to you. We produce 3 different guidelines to guide things like health advocacy and working with physicians in the medical community on the part of families and other individuals who have disabilities. We produce a guideline for structuring community care and supports how to design services in the community. And we produce a guideline for diagnostics and medical care from a physician's perspective. So those are out also on our website. You're welcome to pull those down and circulate them. The last thing that we've been involved in is looking at neuroatypical conditions. We created an expert consultative panel to look at what are the problems that individuals and families and organizations face when they're trying to get an accurate examination of someone who may be showing signs of cognitive decline, but yet have what we call a neuroatypical condition. And here we listed a number of different conditions. Intellectual disabilities obviously was there: Down syndrome, severe mental illness, cerebral palsy, autism, sight and hearing problems, and brain injury, traumatic brain injury and acquired brain injury. So those are what we call the neuroatypical conditions. Oftentimes, when individuals with these conditions present to the physician's office, the individual examiner may not be familiar with the condition enough to know whether they're looking at someone who's affected by a cognitive decline in their older age, or it just is a reflection of their condition, original condition. So this report kind of delves into that. It's a lengthy report, and it's getting circulated worldwide. It's a useful report just to get a sense of what some of the problems that people encounter in these areas. So let's segue over to a little bit of a discussion around intellectual disabilities and dementia, and also look at brain health. Some of the adult life factors contributing to brain risk, and some of these are relatively, you see in the public domain as well. Social deprivation, malnutrition, not getting the right kind of foods, obesity. We do recognize there's a high rate of obesity in most people who have intellectual disabilities. And it might be like their diet, lack of exercise. The issue of adverse drug reactions and polypharmacy is another area. And we just did also an advisory on over-medication, which is available on our website, and talks about what to look for and why you should be concerned about it. Inadequate stimulation, remediation, being isolated and not socially engaged, toxic element exposure, lead and mercury and other factors like that, head injuries and mental distress, and obviously, the substances, tobacco, alcohol, and drug abuse. These are all life factors that contribute to brain risk. A little bit about what we mean by dementia, and maybe just a quick comment about what's the difference between Alzheimer's disease and dementia. And I can't tell from a show of hands if you know the difference, but basically Alzheimer's disease is the brain disease. It's like having heart disease, lung disease, brain disease. That's Alzheimer's disease. It's one of the diseases that affects the brain. Dementia is the behavioral expression of the changes in the brain in terms of behavior. So you will see that Alzheimer's disease usually originates about 25, 30 years before the dementia occurs. So the brain is starting to change. The plaques and tangles, the neuropathology, the amyloid buildup is showing in the brain over time. And that can be affected early on. And that's where a lot of the medications that are being developed now are going to try to address. And dementia basically is when you begin to see change. You recognize that John used to be able to take the bus to his job, and now he can't. He gets lost. He gets off the wrong stop. He's disoriented. That's a function of dementia, most likely, or some other condition that needs to be explored. And it may be affected because he's starting to have problems with his brain. So that's the difference between Alzheimer's disease and dementia. People often use the terms interchangeably, but they're not. So dementia is basically an umbrella term for a lot of different things that affect brain function and also expression of brain disease. And it could be injury, it could be Alzheimer's, it could be other factors. So, and most adults with Down syndrome are at high risk for Alzheimer's disease. That's a very high correlation. It's one of the recognized risk factors under the National Institute of Health for Alzheimer's, which is Down syndrome. About 60% of people with Down syndrome before they die would probably show the dementia associated with Alzheimer's disease. They may show brain changes and never show the dementia, but most do. People with Down syndrome are at high risk for Alzheimer's. That's the same doesn't occur in the other population of people with intellectual disabilities. There's usually the same occurrence of Alzheimer's and other types of reasons for dementia as there is in the general population. And it's usually about 5 or 6% over 60, where in Alzheimer's and Down syndrome, it's about 60%. And the average age of onset, which is basically the time when you begin to recognize some symptoms, in Down syndrome is about age 53 on average. It runs around 3 or 4 years on both sides. In general population and folks with intellectual disabilities, it's about 60, 70, late 60s, early 70s. And then there's the signal changes in Down syndrome usually are changes in terms of personality as opposed to losses of memory. Those are the first things you begin to notice the differences. And also there's a progressive decline in Down syndrome. Because of the compressed aging in people with Down syndrome, their lifespan isn't as long as the general population. They experience the changes of Alzheimer's disease much more quickly, and consequently they have a lot lesser trajectory of having dementia. And then we talk about the advanced dementias, those stages, and we may cover some of that as we go on. But that's one of the issues that we should know about. So why is this something to think about? Obviously, dementia is something that's occurring in greater numbers and as the population ages, and we have more and more older people, so consequently the numbers are higher. With progression, an adult with dementia has increasingly able to provide care for themselves and him or herself. So they require some supervision. It's difficult to create an autonomous living situation for someone with mid-stage to late dementia because the memory will not enable them to remember to do things that are safety factors and other care factors and things like that. So some kind of supervised living kicks in. I imagine you must have experienced that maybe in your own families. The main dementia care options in most agencies are on supporting the person in place, whether it's at home or at their family home, in their own home, or their residential accommodation. The movement now is to create small specialty group homes for dementia care, which is an alternative to ending up in a residential care in an institution or in a skilled nursing facility, which is not something that we really want to see. So there's a lot of call for agencies to become more aware of how their clientele ages and what numbers are they aging and what they begin to have to do about it. What are some of the key differences in adults with intellectual disability from the general population with dementia? Some adults have earlier onset and shorter duration. That's usually the people with Down syndrome, and some with head injury when that occurs as well. There's some differences in symptom presentation, as I mentioned before. People with Down syndrome tend to have a more notable personality change when things start to go south, as opposed to memory loss. They have memory loss as well later on. And the assessments are conducted differently. Generally, an adult in the general population can be seen by a physician, and with standard tests, this physician can determine that this person is not functioning it's a norm, and consequently, they're experiencing some cognitive decline. With people with intellectual disabilities, most physicians don't know how much this person knows and what their function level is like, so they can't determine that in one way. So there are different ways to do that through periodic assessments to look at over time and the changes and becoming more acquainted with the person's previous life abilities and things like that. So why is recognition of onset important? The chart on the right kind of gives you an illustration of the differences when you begin to recognize onset. And the yellow bars are the Down syndrome group, the green bars are the other folks with intellectual disabilities. And onset basically is when you begin to recognize that something's happening. You kind of put two and two together to say, over the last few months, I've noticed that Mary is really having some problems with this, and this. She never had those before. And they're all kind of related to her ability to make judgment calls or memory and things like that. So you're recognizing that something is happening. And that's what, onset's kind of that in that gray area. There's not like a one date you can pick, unless, of course, you have vascular dementia. And then that you maybe recognize that over one time because the person may have suffered a stroke, an embolism in the brain, and behavior changes overnight. But anyway, in other cases, in Alzheimer's, it's a slow progression. So you look for changes and you introduce periodic screening. It's always good to do some early screening after people are in their late 40s, early 50s with Down syndrome, and maybe late 50s, early 60s. So with people with other conditions. And you capture this kind of personal best function, and then you have something to compare against if it starts to change. And alerting staff to be watchful, and this is kind of producing what we call an index of suspicion. The more you learn about dementia, the more you become mindful and watchful in terms of looking for signs. It helps us to begin to reformulate services and care practices. You may be funding some programs that do that, creating safer environments. There's some adaptations you can do to homes to make them safer, dementia-proof them, as it were. You do that, the same thing with children. You child-proof your home. And this is things where people don't drink toxic drinks because they look like their favorite drink. You know, the blue colored Windex is the same thing as blueberry juice for coloring, or Gatorade or whatever. And you don't want them to get into things like that. Introducing cues for movement and wayfinding, engaging and planning ahead for eventualities, because eventually there's going to be a trajectory and people will decline. And then setting the goals for terms of service, you know, looking at the personal service plan, the individual program plan, whatever term you're using, a personalized care plan. Setting goals, what those would be in terms of how you can help that person maintain the skill levels they do have, and they can maintain them as long as they can. And then obviously helping to anticipate parental or caregiver needs as they age, the caregiver's age. Just a very quick walkthrough of the different kinds of dementia, just to kind of acquaint you with them. The difference between Alzheimer's disease and frontotemporal dementia, Lewy body dementia, vascular dementia. I'm just going to give you a very quick point. This chart kind of gives you the technical aspects of the brain change. Let me go to the next one because I think that'll be more helpful. What we see in Alzheimer's disease basically is that you've got a kind of insidious decline and changes of the brain in and loss of memory over starting early and then kind of moving on in terms of more complex memory losses. Frontotemporal, the main differentiating factor is emotional changes and behavioral changes. People's judgment becomes in question. They do things they wouldn't have never done before. They act out of norm. Lewy bodies, when you start to have hallucinations and delusions. These are some of the other things. As you can see, some of the other factors that contribute or add to that. And vascular dementia is when you have a brain stroke, blood vessel blockage, or a brain breakage, and you have a brain part of the brain affected by blood flow. And that's when you change function because that part of the brain becomes inoperative. So some of these things are obviously there. And when the diagnostician gets in there, they look for the differences to see which one this might be. And it's good to know which kind of what's forcing the change in presentation of the dementia and what the reason for it is, because it affects how you provide your services, how you interact with someone, how you communicate, how you set up things, and what the expectation for timing is, the duration of change. The typical age of diagnosis, Alzheimer's, as I said before, 60s, 70s. Sometimes it's an early onset form in the general population. Frontotemporal between 45 and 64. Lewy body, 50 and older. Vascular, usually it's older age, 65 and older. This is a chart that came out of the National Institute of Aging. There's a reference point. I think if I go back on this should be one here for you. Oh, it's not. Okay, it's on a different slide. But anyway, you can Google this if you like. It's a very interesting chart and it's worth exploring. Here's an illustration of what happens with progressive deterioration during Alzheimer's disease. And this is an artist who was an expert in terms of drawing himself and others. And over time, as in the 30 years between 1967 and 1996, he started to have changes in his brain. And in the successive years, almost 1 year at a time, his brain became less and less functional in terms of how he could perceive things, how he could explore them and express them on paper and drawing. And those are self-portraits, and you can see the deterioration in the self-portraits, which is basically equivalent to the deterioration of the brain function. So this is what we mean by a downward trajectory over time in terms of Alzheimer's disease. So that's a reflection of it. It's not something that just stays static, it actually goes downhill. Okay, so the implication of trajectories and duration. The trajectory is basically is that flow, as I just mentioned on the previous slide. Duration is how long it's going to take. And it varies in Alzheimer's disease. It could take 3 years, it could take 20 years in terms of until the person goes into advanced dementia and then dies from complicating causes like pneumonia and things like that. In Down syndrome, it's very shorter. It's much shorter. It's maybe 3 to 5 years. And there are some aggressive forms of of Alzheimer's disease in people with Down syndrome, where they're recognized to have severe changes in behavior. And then within a year, they go right through all those different stages. In the general population, that doesn't just occur that way. So knowing something about the trajectories, it kind of anchors around potential delay of stay in the same location. So you can get an estimate of how long a person may stay in a place that's maybe unsupervised or low supervision or needs high supervision. It provides some ideas about potential changes in their natural occurrences. It creates a schedule for timing in terms of service orientation, planning. This is the big thing here. Knowing how someone may decline over time. If you're working from the obverse, if you're working in nursing and you're treating someone for a disease, from that point of where there's an operation or an interjection of medication, what the timing may be until that person recovers. So that's planning upward. Here we're planning sort of downward, and you've got to accommodate each different condition, what the presentation is, and recognizing that, the early stages of Alzheimer's usually are social kind of interaction issues in terms of providing care and support. When the person gets further down along to late stage, then you're dealing more with personal care and supervision and safety issues and things like that. So you're changing staff patterns, who's expert at interacting with someone on a verbal level versus someone who knows how to change, bed things and bed sores and things like that. So you're also providing an empirical basis for expectations of comorbidities or things that pop up during the course of dementia that are medical conditions that need to be addressed. Giving staff information about anticipating changes, helping with introducing interventions or in terms of day-to-day functioning, and then easing long-term planning for financing, which is a big thing. We're dealing with that now in terms of trying that with the CBS, the heading settings rule. Many states do not set rate limits or rates for people with dementia in terms of homes and care practices. And so our agencies have to argue that there's an issue here in terms of needing more staff, needing more care time and things like that to get the rate raised and things that enable people to get the right kind of care. So understanding dementia, some of the knowns, and then this is going to be a little bit repetitive, but we'll pick it up again. People with ID have the same rate of dementia as the general population. Some exceptions, obviously. Some conditions like Down syndrome, head injury, people who have excessive neurological complications or expectations of low mortality because of genetics will have the rates higher and maybe even die before they have expressions of dementia. And obviously, some people with ID have higher. Some people with ID have higher, particularly Down syndrome and injury. Some percentage of an individual client pool, an agency's client pool, will be affected. We don't know what that percentage may be. Depends on the risks they bring. Early interventions can aid in adapting changes and prolonging periods when the person can function more normally. The effects of dementia will be progressive and eventually lead to death. It's a disease that creates this terminal disease. So we have to contend with that. What are the unknowns? We really can't predict who's going to have it. I mean, there's some more biological issues that are coming up now in terms of the APO4 gene that may target people that say have a high risk factor, but doesn't mean it's going to be expressed in more way than others. How pronounced will be the early changes? What would be coming? They vary in terms of the individual's personality and their factors. How dramatic will be the changes? How long the person will live after diagnosis? What other diseases or medical conditions may be coincident? And what particular dementia-related behaviors will be more evident? People vary in terms of what they bring. It's like, I hate to say it, it's a comparison to someone who's highly has had too many drinks. You don't know how the expression of behavior may be. They may be very friendly, they may be very aggressive. So it's an expression sometimes of what's underlying the behavior and the personality. So some of the expectations of change. Cognitive skills will decline, support needs will increase. There'll be an increased risk of falls and injuries. There'll be problems with swallowing dysfunction, clots, pneumonia, bladder infections, nutritional deficiencies, and seizures. So there's a medical aspect to this. We have to consider that. Care factors, you have to watch for signs of abuse and neglect, and including self-neglect. Someone who's living autonomously in their own place, if you start to see changes in them, they're not washing and not eating well, they're maintaining a dirty household and they're not caring for things. There's self-neglect, and there may be expressions of that you may be worried about, and it may be coming out. That's an early sign of cognitive decline. It may be also abuse by caregivers, which is another factor when someone becomes even more infirm. because they have an intellectual disability on top of, or in addition to dementia, and the caregivers just take advantage of them. So you have to be careful with that. Watch for signs of caregiver burnout. And in general population, also in stress at home, this affects the adults' behavior. If they recognize that something's happening to their caregiver, they get emotional about it and they express behavioral changes. And then watch for advanced dementia. There'll be signs when the person is starting to decline, that the mobility will be not very effective, less interested in things. They won't track things. They won't interact. Language would disappear, things like that. So we have some ID-associated issues that extenuate these factors. There's some people who have coincident conditions. Comorbidities and diseases may be a factor. There may be mental health issue overlays. There may be late onset seizures. That happens in people with Down syndrome. It's one of the signal signs. If you start to see seizures in someone with Down syndrome in their 40s or 50s, they've never had seizures, that's a good indication that something's going on. Most people with Down syndrome have what we call precocious aging or early aging. And by the time in their 50s, their 60s, their 50s, they're looking at 70s and 80s. So they have about 20 years ahead of time, the rest of the population in terms of presentation of geriatric symptoms. Expressive language difficulties, nutritional deficiencies, and diet inadequacies, and the presence of polypharmacy. So these are all factors. So what kind of services? This kind of gets you into, okay, what can I encourage organizations in my state to do? One of the things that we're trying to push through NAPA a lot in the Alzheimer's plan is the preclinical symptom phase. Look at periodic screening, especially if you're working with high-risk populations. If you know that there's a high risk for dementia in people with Down syndrome, you want to screen early, late 40s, early 50s, to see if you can pick up changes. Because if you do it earlier, there are things that can be done. I mean, there's some medications that kind of slow down a little bit of the effects of Alzheimer's disease. And there are new medications now that are looking to treat amyloid buildup, which is supposed to kind of bring people back a little bit. And the two that are FDA approved are sort of on that questionable stage, whether they're really having strong effect. They've shown that they reduce the amyloid in the brain, but they haven't shown considerably that behavior has kind of come back and how long that will last, because the trials weren't that long. We'll see where that goes, but that's where everybody's investing their energy in these days. So screening is important. And the tool that we developed at the NTG does that. Assessment diagnostic phase, referrals for assessment. Finding a diagnostician that understands the difference between an intellectual disability and dementia is difficult. And maybe we can count them on a hand or two hands around the country that we know that are experts in this area. So, but it's hard. And anything you can do to support the recognition of physicians in your areas and states that do this well is important, and putting something together that would give families some place to go, a resource booklet or whatever, or working with the Alzheimer's group, Department of Health or whatever, to get this information out would be very helpful. And then what we call the post-diagnostic support after someone's been diagnosed. The supports for continuing with family, that's important if they're still with their families when available and appropriate, just as is. The Alzheimer's Association is a great aid in that area. They have lots of helpful materials. Interventions, what we call the behavioral and psychological symptoms of dementia. These are the behaviors that are problematic. Wandering, shouting, crying, doing things that are just out of norm, that are difficult to maintain your temper about something happens. The health reviews and surveillance being on top of other things that may be happening physically to the person, and so they just don't count them off just because they have Alzheimer's disease or dementia. The proper screening and assessments for coincident conditions. They may still have a cardiovascular disease. They may still have other respiratory disease or other factors. And then maintaining health by nutrition, exercise, or encouraging walking. Wandering has an upside too, besides just kind of wandering out, getting lost. You don't want to do that. But if you have an enclosed space, many homes like that have a large yard that people can wander in, or inside the building. So it gets exercise, it gets them going, throws off some of that energy they have, as long as they don't go out into traffic and then they get lost. That's an issue. So that's it's a whole different system about locking and not locking. And the supports for dementia care, capable care in the community as the disease progresses. All these things have to be put into play. And then, planful efforts to create systems of care is an important factor in the state, to know what's coming ahead and plan for that, and obviously supporting caregivers. So what could I advise you to can be done? I think certainly improving understanding of aging and dementia, whatever materials are out there. And we have some, the National Institute of Health and Aging has some, National Down Syndrome has some, other organizations have some wonderful materials available on the net that people can download and read. So if you can pass those out to family members, pass them out to agencies, staff, direct support staff, others, improve their understanding. So they're more aware of something that's going on in an individual as they age. There are things that people change. There's normal aging processes that cause change, and you have to know what to expect. And don't feel that that's a bad thing that's happening. It could be a good thing because it's just natural development. Be alert to risk and early signs of decline. Look for those signals, what we call the index of suspicion. Adapt living environments to minimize risk. Watch those scatter rugs and watch those electrical cords that's strung across a room or something. Watch other things that may cause danger where someone stumbles and falls, bumps into things. Look at the coloration of the room and see if there's any things that cause threat. Look at the shadowing of lights, whether they cause anxiety in someone if they see them. Health with futures planning, what are some things that come into play? Aid with families who are providing primary care, enhancing staff skills, putting energy into training, quality checks on services, providing stage-related services. There are different stages, and look at how each stage has a little bit different focus in terms of how they help people, and obviously planning for the future growth of the aging segment of your population. Each of our states has got a population that's growing. I live in Maine. Maine now, I think, has got more people than Florida who are proportionally age. Yeah, I'm surprised too, but we all move here like we do in Florida for some reason, different reasons, I guess, maybe political, otherwise, or weather or whatever. But we like the ocean. That's the commonality. So that's other things to do. Okay, so I'm going to close up with some thoughts. I think, talking about basically looking at it, taking a lifespan perspective. Look at these things from what happens in younger age influences older age, and older age influences younger age. One of the good examples of that is in cerebral palsy. People who have been encouraged as young people to walk as opposed to use assistive devices, when they reach their 50s, they kind of max out in their muscle ability, and they then it was more difficult for them to walk. And those that haven't done that oftentimes find that their walking ability is extended longer. So there's these kinds of things that happen at younger age that affect older age and vice versa. And we can learn from, I guess what we mean is we learn from older age what we should change in younger age. So how can we help? I think we can reduce stressors, certainly, improve mental health and consequently brain health if we can avoid having things that people get stressed about, environments. I have a colleague who does some good training about mindfulness. Larry Force, some of you may know him. He does a very nice program on this to kind of help staff and people and family members to kind of get in touch with what's going on around them so they don't get stressed out. Consider nutrition and weight, avoid overweight, which leads to disease. Check those nutritional charts and what people are eating to see if they're relying on takeout food from fast food restaurants as opposed to nutritional food that they can get. Grow themselves even. Promote social inclusion and involvement, stimulate cognitive capacities. Look at the total life situation. Who's involved? Who helps? Who influences? Look at this whole pairing of what's around an individual, and stimulate planning. Get systems involved to aid lifespan health and later age outcomes. And then targeting risk reduction, and kind of going back to brain health. You've got a public health agency in your state. It's called whatever it is, Department of Health, whatever. Request them to involve when they target brain health measures and activities, which more are doing. Make sure that they involve people with intellectual disabilities. Target them as well. Don't let them say, "Well, that's your business, your agency's business, not ours." Get them involved. It's a public health issue, and it involves the whole public, not just one segment of it. Engage the Developmental Disabilities Authority, the state agency, to improve healthy life situations, practices among their adults. Maybe through regulation or oversight of agency practices and things like that. Provide materials that enhance education and information uptake among individuals who have intellectual disability. Excuse me. And then, if you can influence the medical school training and continuing education, which I know is a high bar to try to cross, the curricula, so practitioners are much aware of how more surveillant of compromising coincident health conditions. And they look at what affects brain health in people with intellectual disabilities. over the lifespan, and particularly in middle age and later age. There aren't that many specialists out there who are medical specialists or people who are older who have intellectual disabilities. And then obviously bridging the networks, the silos, we have the aging silo, we have the IDD silo, we have the health silo, and trying to bridge those together it's a common effort around what you're doing. I suspect from some of the demonstrations you're doing, you're trying to do that. So it's to your effort, to your credit to your effort. And then look at the scope of aging. Recognize that as people develop with age, the focus of services changes. There's a transition to retirement activities, social things more, lifestyle changes, the variations in aging trajectories. People age differently. If you go back to a high school reunion now, would you recognize all these old people, or would they say, "Oh, some of these people are same age as I am"? That kind of thing. Refocusing medical concerns. I can see you laughing, Donna. Refocusing medical concerns, and then non-vocational activities, which are important. Kind of find alternatives to work, but not just sitting around. Needs for variability in housing and daily supports, and health considerations that provide a clinical focus, such as both on physical and mental health. And remember that adults over 60 are a heterogeneous group. You're talking about a lifespan of maybe 100 or 40 years, from 60 to 100. There are a number of people who survive over 100 who have intellectual disabilities. We did a study in New York that found a group that was centenarians and 90 years old. So there's like a 4-year window there of varying trajectories in terms of how people age, and in terms of their health capacities and their health status and needs. So, designing programs for our over age 60 population is not a one size fits all approach. And then the Older Americans Act is a critical thing to help. There's a lot of things that go into that act that provide to people over 60, and some under 60 if they're eligible for like nutrition programs, go with a caregiver and things like that. So you can tap into those services as well. And then I'll just leave you with this one last thing. Thinking about activities at all levels. And it's kind of borrowed from some folks up in Canada, but I think it struck me that this is a helpful thing to look at. Starting at the top, look at the upstream activities. What are some of the things that are the big global things that you could affect through mechanisms from the council? What are the things you could change at the macro policy level in the state? What can you influence nationally? What about diminishing the causes of the causes? These kind of like big social issues. And then the midstream interventions, the intermediate things that these things, the changes that generally occur at the micro policy level, which you can affect regionally and statewide and locally and organizationally. These you can probably affect more easily. And these are about changing the causes. And then downstream interventions are those things that are the immediate needs of a populations that are marginalized. These are the things about changing the effects of the causes. So you can approach these from, okay, do this today and it'll affect it tomorrow, or I can do this today and it'll affect me 3 months from now, or 6 months from now, or 3 years from now. So, it depends on what horizon you're working from, but these things do have an effect. So this is our website. If you're interested, you can go scan it, some of our publications, and I welcome you to come. And I'm open for questions. I think we have a couple minutes.
We do. Matt, thank you so much. And I think that not this slide, but the one just before really will give you guys some deep things to think about if you're part of your state project. And most of you who are on live today with us are part of one of the Bridging Aging and Disability networks. So this is some really good thinking about those upstream interventions, midstream interventions, and downstream interventions where your project might be able to jump in there with something. I know that we had a question from Jody. Jody, do you want to pop in and ask your question?
Yes. Hi, Matt.
Hi, Jody.
Sorry, I'm not on camera. I'm really unpresentable today.
It's early in the morning, I know.
I wanted to ask you sort of about EDSD and the recommended age for people with Down syndrome for the baseline.
Yeah.
I know you had said that might be changed. I'm curious if there's been any progress on that.
Basically around, I think from our 835 on, if you're using it with Down syndrome.
Would you be changing that in the actual document, the form?
I don't think it makes a difference what it says on the form. You can actually, I give you permission to use it with any age.
Really? Because it says 45 on that.
Yeah, we did that form 10 years ago.
Yeah.
And we haven't changed it because it's published in 16 languages. And we lost one of our
Oh,
translators around the world that did the
okay.
original translation. So that's what that coding is back. But don't worry about the age. Do it whenever you think it's appropriate.
So it's safe to say recommended at 35 for people with Down syndrome, but
I
what
would,
about
yeah.
everyone else? Is it
I
still
think you go up the
45?
scale. I think about 55 or so with other
Oh,
folks.
wow. Okay. Thank you.
Yeah, because look at when the average age of onset Down syndrome is about 53. The average age of onset in folks with other kinds of intellectual disabilities is early 70s, probably late 60s. So you want to
Thank
be before that.
Thank you
And
so
there's going
much
to be
for
more.
this.
And with Down syndrome, there's a lot more variability in terms of the early onset issues because of the precocious aging. So 35 is not
Wow.
a bad time to start picking up something. It's
Thank
good to
you.
have that baseline.
Thank you so much.
Yeah.
Are there other questions for Matt? I am hearing some silence, but here's what I want you guys to know. Matt, as I said at the beginning, is one of our TA providers on this grant. So Matt is available to you in our materials on our website for the Bridging Aging and Disability Network grantees, and in your Facebook, you have direct connection to Matt, his contact. We will send out this presentation again with Matt's contact as well. Matt, do we have your slides so that we can get them to this?
Oops, there's the email address if you want to contact me at the university.
Right.
And
So that is available to you for consultation if you have, whether it's follow-up questions to the presentation today, or if you want to run some thoughts by him as you're thinking about what you're doing, either as part of your grant project or your council has some interest and is doing some work. So please do utilize this amazing resource that we have within our network, and Matt and others who Matt works with. Daintree, before we close, I know that you're doing some deep work with your project on this. Was there anything that you just wanted to share? I don't mean to put you on the spot, but I know you, Daintree, you always, have something to share.
I'm sorry, one more time.
Because we know that Hawaii's project is going to be really diving into the dementia issue. Was there anything that you just wanted to share with folks about what you're looking at or how you're thinking about it?
Yeah, so with the dementia and categories, this year we joined up with the Alzheimer's Association for our Day at the Capitol event. So what we have done is we have grown our collaborators and working together and making sure they realize the difference when it affects an individual with an intellectual developmental disability, especially those individuals with Down syndrome, no S and down. And so that is something that we've really been working good with the legislators this year. We had a day event at the Capitol. And so that's something that we've been working with, as well as an internship program, bringing high school students in to work with people with developmental disabilities and seniors. And so we're trying to expose people to the need similar, but yet they're still a little bit different. And so we want to make sure that people recognize that and see how we could collaborate funding and services and supports, but yet still realize the differences as well.
Great. Thank you for sharing that. So maybe that's some inspiration for other states.
We're really working too, Donna, with the ADRCs, really highlighting that D and the disability part of it and seeing the correlation there as well. So our ADRCs, we've been really making a huge difference with them. Even their website, we're making sure that they identify the D and the support services from there.
Right.
So that's those two big major things that we're working on.
Excellent. Any final questions? I know we're over time and you've all been very generous with your time, but I just want to make sure that we've answered or gotten a connection for you if you have anything else that you need to ask or share. All right. Well, Matt, again, thank you so much for your generous time. Great slides. I heard so many important things in what you shared, especially, a few times you mentioned the word planning, and that's what these folks do. They are planners. They are working within their systems in their states. They are changing or attempting to change, whether it's one specific tweak that can be made to build better connections between the aging and IDD communities, or it's big change. We'll see how these things play out, but so much that we can take away from this and so much learning. And you're right, dementia is out there in a big way right now. I think we're hearing a lot more about it in general, and specifically, I think a lot more with the disability population. Some of that, again, because of the baby boomer generation and more people aging, and maybe some relationship to COVID as well, and what our brains went through. And I think over time, we'll learn more about that. But Matt, thank you so much for sharing
Pleasure.
all of this with us today.
Yep. Good to see you. See you
Good
again
to
sometime.
see you, and great to see everybody today. Thank you for your time.